Hello, welcome to APP virtual lectures. My name is Sharon Best. I am a physician assistant and I practice in a very specialized niche of OBGYN gynecology called NaPro Technology. I'm very excited to share with you a case presentation of a young woman who came to me with a past medical history of recurrent pregnancy loss. Using NaPro Technology Protocols, we were able to diagnose the root cause of her losses, treat them, and she was able to achieve a pregnancy and bring that pregnancy to full term and have a successful delivery. So the objectives today will just be to briefly tell you what is NaPro technology. We'll look at the etiology of recurrent pregnancy loss, which is always multifactorial, and I'll share the case presentation. So this is an image of a website that I created that is truly educational. I use it to teach my patients at every single clinical visit, and I also share it and hope it will help some new NaPro providers entering into this specialty. As I mentioned, we pretty much will treat any gynecological condition that will walk into a regular OBGYN office, and we look at the patient holistically. So obviously, we're going to address thyroid problems, anxiety, and depression. We specialize in something called progesterone support during pregnancy. I have a personal mission to get out to the world that what we do in NaPro is based on research and it's excellent medicine. Many of the OBGYNs that end up delivering my women tell them there's no need for the progesterone during the pregnancy. Dr. Kumasari was the first author for the PRISM and PROMISE trials that looked at the efficacy of progesterone to prevent recurrent miscarriages. The conclusion will say there was no statistical significance showing a benefit. However, Dr. Kumasari recently did a sub-analysis, and in his little talk on ViewMedi, he tells us that he himself is using bioidentical progesterone, just like we are in NaPro, for his women that have had recurrent pregnancy loss. He reinterpreted the data, again doing a sub-analysis, and in his opinion, the progesterone is worth giving for women, again, with recurrent losses. So please, here's the website to take a look at Dr. Kumasari's talk. It would be well worth it. Everything that you see with a red asterisk here, the first line treatment is the birth control pill. In NaPro technology, we take our women off the pill and we treat them again with micronized hormones. So if they need estradiol and progesterone, we'll give them estradiol patch, which is bioidentical, or Prometrium, a micronized progesterone. If they only need progesterone, we will supply that for them only in their luteal phase, which will mimic the normal menstrual cycle and allow them to maintain their fertility. Obviously, when we're putting these women on the birth control pill, we're rendering them completely infertile. We're shutting down the entire cycle. It's logical that that is not healthy. I recently had a patient come to me who was placed on the birth control pill for, quote, a diagnosis of PCOS at 14 years old, which we all know is inappropriate. She probably had long cycles due to an immature HPO axis. However, she's 31 and she was on that birth control pill all the way from age 14 to 31. So that cannot be healthy for our young women. Now, you can't talk about the NaPro technology without talking about the Crichton model system of charting. Dr. Thomas Hilgers from Omaha, Nebraska, started the St. Paul VI Institute. That is where all NaPro providers are trained. So you can be a medical NaPro provider if you're a PA and NP or family practice or OBGYN. You can undergo a 1-year surgical fellowship at the St. Paul VI Institute if you have completed the normal GYN residency. Women are taught to track their menstrual cycles in a very nuanced and standardized method. If they are ovulating, they are taught to recognize a peak day. So ovulation will occur within 48 hours in about 96% of patients before or after the peak day, and in about 99.6% of patients in 72 hours before or after that peak day. In NaPro technology, we have a routine protocol that we will draw what we call post-peak panels or luteal phase panels. Those panels, the women will go to the lab on the 3rd day after the peak. We call that peak +3, and then on 5, 7, 9, and 11, and they will have progesterone and estradiol levels drawn, and we have about 30 years of research at the St. Paul VI Institute to establish norms for those particular days. There's many other biomarkers that we will look at in this chart. And I do recommend when I'm doing a diagnostic evaluation using NaPro, that the woman use this chart and not any other method of NFP, because, for instance, no other method is going to teach a woman to recognize something called 2Ws. So a 2W is a wet type of mucus that's not lubricative. For instance, if the woman has frequent 2Ws in her post-peak phase, it's a biomarker that lends some way that she may have a condition called chronic endometritis. So we're all familiar with acute endometritis, but chronic endometritis is a hot topic of research right now, especially in the infertility world. We know that women have a low-level chronic infection in the endometrium that is completely asymptomatic, with the exception of infertility and recurrent pregnancy loss. And we can pick that up in a biomarker on this chart, and we can treat empirically if we think that is the best course of action for a woman. You're looking at a table taken from the 2012 committee opinion from the American Society of Reproductive Medicine. And as you can see, the etiology of recurrent pregnancy loss is always multifactorial. It's very difficult to do a good randomized controlled double-blinded placebo study on the etiology of recurrent pregnancy loss, because each woman is individual and each woman will have a different constellation of causes for her specific recurrent losses. If you look at this column here, we all know that we have genetic causes. We all know how to rule out any phospholipid syndrome. Obviously, we should look for structural abnormalities like congenital uterine anomalies. We have to make sure the patient's tubes are open. There's hormonal and metabolic problems, uncontrolled diabetes, thyroid disease, prolactin abnormalities, and we look at luteal phase deficiency, which by definition is low progesterone in the post-peak phase. There's infectious causes. I've already mentioned the chronic endometritis, and of course there's a sequelae of recurrent STDs with PID being a factor, and then there's also male factors. Now here's the case. So this is a 22-year-old gravida 2 para-0. She had 2 spontaneous abortions. I met her first in January of 2023. She had 1 miscarriage at 6 weeks, the second at 4.5 weeks. She'd been married about a 1.5 years, and the couple had been open to pregnancy for the entire time. She saw another NaPro doctor about a year before me in January of 2022 in another state. And this NaPro doctor told her it was okay to bypass the charting. So if I can give you any advice or tidbits, if you're starting out at NaPro, it would be do not bypass the charting. I have had multiple patients who have seen other NaPro doctors who told them to look for stretchy mucus, and then they drew their post-peak panel that I mentioned based on that, and there was misdiagnoses and there was mistimed treatments, which is what happened to this patient essentially. So she was told to look for stretchy mucus. A post-peak panel was drawn. Again, that's on P+3, 5, 7, 9, and 11, and we're looking at estradiol and progesterone, and we're matching them to NaPro norms. She was diagnosed with a luteal phase deficiency, hence low progesterone in the post-peak phase, and she was started on the typical starting dose of micronized progesterone, 200 milligrams PO on P+3 through P+12. Now, it's very important to understand this is not the progestin that we have in our birth control pills. This is a micronized progesterone. It can be bought as Prometrium in a retail pharmacy or obtained by the patient in a compounding pharmacy. This particular patient also had a diagnostic laparoscopy. Tubes were open, no endometriosis was found. Per her report to me, she was told she did not have thyroid, or she did not have PCOS, and her thyroid function was normal. However, what she did tell me is when she started that progesterone, she said things got worse. I had 2 cycles where I didn't ovulate, and she knew she was ovulating before, or thought she was. She had some new mid-cycle pink spotting. She had premenstrual brown spotting that she had not had before up to 4 days. She also felt she had brain fog, and her weight was harder to control. So she went off this about a month before she saw me on her own. When a patient tells me that, I'm almost sure that they are mistiming taking this progesterone. And again, that is an issue because she is not charting using the Crichton model system. We know that the LH monitor is inaccurate in women that have PCOS, and we know that LH monitors are inaccurate in most women that are suffering from infertility. They are accurate in women that have normal, healthy menstrual cycles, and that is not most of my patient panel. So in the medical interview, I asked her, what was the shortest and longest cycles that you've had in the last 2 years? Now, many times providers will just say, tell me about your cycles. How long are they? And the patient will give you an average. So maybe 28 to 34 days. And you won't think anything of that. But if you don't ask shortest and longest in the last 2 years, you may not get the pertinent information that you need. So this patient told me 21 to 42 days. So right now, she has met one of the 3 criteria necessary for PCOS. In order to diagnose PCOS, patients have to meet 2 of 3 criteria. The first criteria is long cycles, greater than 35 days, or shorter than 21 days, if the patient is 8 years past menarche. The second criteria is either clinical hyperandrogenism. So by her story, she has high androgens, acne, loss of hair, additional hair in the male distribution, or a biochemical hyperandrogenism. A lot of providers think you must have high androgens in the serum in order to meet that criteria, but you don't. The patient can give you a story of significant hyperandrogenism clinically, and that is per the 2023 PCOS guidelines. So I asked her about acne. She had significant acne right along the jawline, the classic distribution of PCOS. She had a little bit of acne also on her chest. The way that I ask about hair growth is, do you pluck, shave, or tweeze hairs in your upper lip, in your chin? Do you shave above or below your belly button? That is a better way to ask. You would be surprised how many women have hair that they are taking care of. She had just a few hairs on her chin and a few below her belly button, some on her lower thigh. Obviously, not enough by the Furman-Galloway scoring system to give her a diagnosis of hirsutism, but we still want to ask about this hair growth. It lends a little weight either to or away from PCOS. I asked her about PMS. So we know from NaPro that when women report these PMS symptoms are very severe and they're starting a week or even 2 weeks prior to the onset of their period, that is probably reflective of a luteal phase deficiency or low progesterone in the post-peak phase. We can really treat PMS well by giving them progesterone and matching those therapeutic levels to the norms that we have found. Some women are having PMS and they're feeling awful for half of their cycle every month. So it may start as much as 14 days prior to the period. After this medical interview, my favorite diagnosis was PCOS, luteal phase deficiency because of this PMS symptoms, possible endometriosis, even though she had a laparoscopy. Surgeons have varying amounts of skill, and some are able to find very subtle, small ectopic implants that don't look very typical, and others might miss them. So that's still up there in my differential diagnosis. And a big one is chronic endometritis, that low-level bacterial infection in the endometrium that has no symptoms other than recurrent pregnancy loss and infertility. And a possible ovulation disorder. NaPro is able to diagnose different ovulatory disorders by doing follicle scanning. We usually do that towards the end of the workup if we've been unsuccessful in achieving a pregnancy up until that point in time. So my plan after the first visit was to start charting with the Crichton model system. We were going to do the typical cycle day 3 labs. We look at thyroid, we look at androgens, we look at general health labs. We often look at insulin to look for insulin resistance. We know that high insulin is associated with recurrent losses and infertility. We can easily address that. And then obviously FSH, LH, and estradiol levels on this cycle day 3. We also order a cycle day 5 ultrasound. We're looking to meet that third criteria for PCOS, which is PCOS ovaries. It has to be done very early in the cycle before she starts to develop any of her eggs. I asked her to start a prenatal vitamin, and I requested the medical records from the previous OBGYN. Just to take a look at these different phenotypes. So there are 4 phenotypes for PCOS. Again, we have to meet 2 of the 3 criteria. Those 3 criteria are long cycles or very short cycles, clinical or biochemical hyperandrogenism, and polycystic ovary morphology. So many clinicians are still under the impression that the patient has to have a lot of follicles in the classic string of pearls distribution in her ultrasound, and that is not true. According to the International PCOS guidelines, the patient can have either 20 follicles in a single ovary that are between 2 millimeters and 9 millimeters, or she can have 1 ovary that is greater than 10 mils total volume. And we have a calculation that we use. It's the 3 dimensions. You get the sum of the 3 dimensions that are reported to you, and you multiply that by 0.52, and that gives you the total volume of the ovaries. So the patient can have either or, so 20 follicles or an ovary greater than 10 mils, and that only needs to be in 1 ovary, not both. Phenotype A has all 3 of those criteria. Phenotype B has the long cycles, the high hyperandrogenism, but no PCOS ovaries. And many clinicians don't realize you don't need PCOS ovaries anymore to make a PCOS diagnosis. The phenotype that is missed most often is phenotype C, and that's because these patients are ovulating. And many clinicians think PCOS is long and ovulatory cycles. It doesn't have to be. A phenotype C has normal cycles, they are ovulating. These patients have large ovaries and clinical or biochemical hyperandrogenism. And a phenotype D is supposed to be the most rare type. However, I've seen it very often where it's long cycles and polycystic ovaries, but no hyperandrogenism at all, either clinically or biochemically. This is the patient's follow-up visit. So her health lab CBC was normal, kidney and liver function is normal, vitamin D was wonderful. We like her vitamin D to stay between 50 and 75. She's right in the middle. Her reproductive labs, she doesn't have the classic PCOS appearance of the reversed FSH LH. She does have estradiol that's a little bit on the higher side for cycle day 3. We don't have norms for this, but when you look at it over and over and over, you start to get an idea of what is kind of normal on cycle day 3 and what's on the higher side. She has prolactin, which is great, 11.3. I did the typical hypercoagulable workup for antiphospholipid syndrome. She was negative. And look at her pelvic ultrasound on cycle day 5. Her right ovary is 12 mils total volume. Her left ovary is almost 11 mils total volume. It was reported that she had multiple small follicles. I don't need to count them because she meets criteria for polycystic ovarian morphology already. I talked to her a little bit about NaPro's specialty in doing something called a bilateral ovarian wedge resection, uterus, tubes, ovaries that are quite large and bulging out. What we do is we take a pie-shaped wedge section, and then these 2 sides are opposed and sutures are buried to minimize the adhesion formation afterwards. And we took a look at the office visit notes from the prior NaPro doc, and what I picked up was her post-peak panel was indeed mistimed. She was indeed mistiming her progesterone dosing. Again, just looking for stretchy mucus and not charting. And the reason I know this panel is mistimed, because P+7 is usually the highest among them. It's a sine, it looks like a sine curve for 3, 5, 7, 9, and 11. Her P+7 is the lowest, so I know this is not timed correctly. She missed the P+3. She did a P+12. We have no norms for P+12. So she had half a panel mistimed, and that was the explanation why she didn't feel good. So I convinced her to give the micronized progesterone another try, which she was willing to do. Her other labs, thyroid was great. Androgen profile, not a surprise. She's high with the androgens. She had already met PCOS criteria. She had long cycles and she had big ovaries. Now we just have a slam dunk. She has a PCOS phenotype A with all 3 criteria being met. She has, and we know that sex hormone binding globulin is going to be inversely proportional to those high androgens, and everything matches here. Her biomarkers on her Crichton model chart were great. They looked perfect, with the exception of a continuous mucus cycle at 15 days, reflective of that high chronic estradiol that she has that you saw on the cycle day 3 labs. I did do a deep dive for glucose and insulin 3-specimen testing. So everyone is sort of used to seeing a glucose 3-specimen. This is totally normal. I go by the American Diabetic Association guidelines for what are the upper limits for that, which are 90 at fasting, 160 at 1 hour, 140 at 2 hour. She was well under that with no problem. On multiple occasions, I have seen glucose totally normal and insulin through the roof. So the glucose is not enough. I do a 3-specimen insulin along with that. After the patient goes fasting, she drinks a 75-gram glucose drink, the glucola, and then she has a 1 hour and a 2 hour. Now I looked at the literature for what are the norms for the insulin. We have norms somewhat established for the fasting, which is about 10 to maybe 13. There has been literature and there has been efforts to establish norms for insulin for the 1 and the 2 hour for many years, in fact, decades, and the publications are contradictory. We've not been able to come to an agreement on what those levels should be. However, NaPro Technology will usually want this 1 hour below 100 and the 2 hour below 60, and some NaPro providers prefer it even lower than that. So my plan for her was I usually give the patient with a diagnosis of PCOS the option to use metformin, or we have a supplement called myo-inositol and D-chiroinositol at 2050 that we have wonderful data to support is very effective in 1, driving high insulin levels down, and in 2, promoting ovulation in women with PCOS. According to the 2023 guidelines, it is appropriate to start a woman with PCOS on metformin, even if she doesn't have high insulin levels, in order to promote ovulation, which we know metformin does by some unknown mechanism of action. I give them a choice. I like the metformin. I think it works a little bit better just because I have seen myo-inositol with high insulin levels. I use it, it brings them down. But when the levels are very high, it doesn't bring them down enough. Vitamin D, I started her on a maintenance dose of 2,000. I've learned since this time that that is too low. Her vitamin D will drop. The maintenance dose that seems to work for me is 4,000 international units 5 days a week. That seems to be the best to keep the women right around the 65 level. Again, our goal is between 50 and 75 for the vitamin D. I told her, let's draw some post-peak panels now. We'll time them to the chart, and let's do a semen analysis. So we do a semen analysis in NaPro a little bit different than it's done in mainstream medicine. Masturbation is the preferred method to obtain the specimen. For NaPro, many of our women are Catholic and they're uncomfortable giving a specimen like that. So we collect a specimen during the natural active intercourse, which allows the pre-ejaculatory fluid to be collected as well, which doesn't typically happen with a masturbation collection. We have the patient purchase a polyurethane condom. I use a company called Recurrent. I have a whole webpage dedicated to this semen analysis. Recurrent will send the patient a home kit. They will put a few holes in the polyurethane condom, which will allow the active intercourse to be open to the transmission of life. They will have intercourse in the usual way, and then the man will pipette the specimen from the condom into a sterile container, and it will be shipped expeditiously to Recurrent. We will be given results that look exactly like the results that are given in any other semen analysis. So the semen analysis, the condom broke, and I asked them to repeat it, but the husband didn't feel good about it. The wife didn't feel good about it. They didn't want to repeat it. We had drawn her post-peak panel, so we reviewed that, and this is an excellent panel, very telling. Her P+3 was actually on the high side. Her P+5 came out on the higher side, and these are being compared to the NaPro norms that have been established over 30 years. Her P+7 came out normal, but low normal, and then she had a very precipitous drop from 7 to 9 of 50%. That is specifically criteria that meets our luteal phase deficiency type 3. And I'll tell you a little bit more about that on the next page. So the plan was to start the progesterone 200 milligrams on P+3 through 12. I was going to check P+7 and P+9 levels. I wanted to make sure that these were adequately put into the normal range. We don't mind if she's a little high in the early cycle. We want that endometrium primed really well in order for her to receive a baby and to hold on to that baby. And she was told to have fertility timed intercourse, which is going to be around her peak day. This is her actual chart. She's going to have intercourse around her peak day. I discussed a little bit about the option of the bilateral ovarian wedge resection, but I always prefer to work with my patients for 6 months medically before I put them at a surgery because all surgeries have a risk. Here's the luteal phase deficiencies. We have a type 1 and 2 that we see very often. The type 1 and 2 have low progesterone across the board on P plus 3, 5, 7, 9, and 11. The difference is type 1 will have a very short post-peak phase. The post-peak phases that we look at as one of the biomarkers on the chart, we expect it to be between 8 and 17 days. When the patient is under 8 days, it is telling us they have very low progesterone. A type 2 has low progesterone, again across the board, 3, 5, 7, 9, and 11, but they have a normal post-peak phase. The type 3, which is the one you saw the patient has a normal or high progesterone on P plus 3, 5, and 7, and then they take an abrupt drop. It has to be greater than 50% to meet this criteria at P9 and 11. So she met it perfectly. Interestingly, what we know is 1 and 2 is probably a follicle that is not maturing well, so it hasn't made a very robust corpus luteum. If the progesterone is not adequate, the endometrium is not primed. Remember, it's progesterone that causes it to change to a secretory type of histology to allow that baby to be nourished and maintained in that endometrium. However, that precipitous drop tells us the problem could be an endometrial receptivity problem. So what are they? The most common is low progesterone. We can easily fix that by giving her micronized progesterone replacement cyclically every month on P plus 3 to P plus 12. And the other big endometrial receptivity problem is chronic endometritis. Again, that low-level infection just sitting in that endometrium with no symptoms whatsoever except infertility and recurrent pregnancy loss. Type 4 and 5 I rarely see. I really see 1, 2, and 3 all the time. The patient then came for the well woman exam. She was due for a PAP. Everything was normal, like it always is. I now practice 100% telehealth. It's very easy to have the patient go to a local OBGYN once a year for annual well woman, and I just ask for that report. And every 3 years, they have a PAP. And now the patient came back. We're now in June, and we have therapeutic P plus 7 and P plus 9 levels. So this is to monitor the therapy. I have her on 200 milligrams, again on P plus 3 through 12, and she has a high P7 and a high P9. So I'm okay with that. We know that the extra progesterone is not harmful at all. The patients feel wonderful on it. They feel their mood is better. They sleep better. When it's timed properly. When it's not timed properly, they feel worse. She felt great, much better with it. I would rather see that progesterone a little bit on the high side because she's having recurrent losses. I want to make sure that endometrium is primed really well. The patient went ahead and scheduled herself with the OBGYN that I have a number of OBGYNs that are NaPro trained that I refer patients to. Dr. Blaise Milbrone is in Ohio. There's a NaPro doctor here in Pennsylvania, but she books out about a year and a couple of months, so she's very hard to get into. Generally speaking, and then we can also send them up to the St. Paul the Sixth Institute. There's wonderful NaPro physicians up in Nebraska. She scheduled the surgery. I was a little uncomfortable. I said, hey, we don't know if the semen analysis is okay. I haven't had a lot of time to work with you. And she said, I really want it. I want my big ovaries to be smaller. So I documented that the patient really wanted the surgery and she went ahead and had it. So MR did end up going for her NaPro surgery. She had that done on July 6, 2023. She had a bilateral ovarian wedge resection. An endometrial biopsy was done. NaPro surgeons are well trained to identify areas of the endometrium that look like there is chronic endometritis there. This is a hysteroscopy. This is a normal appearing endometrial tissue. This is a strawberry poikiling, which is the area that they will direct the biopsy. This biopsy must be sent for a specialized stain. The CD138 stain is the gold standard to diagnose CE. And when that stain is positive, the specimen has to be sent for culture and sensitivity. MR was found to have chronic endometritis. Pathology report revealed it was a group beta strep, the agalactica, same type of strep that is found, women are checked for when they're pregnant at around 37 weeks, kind of harbors in the vaginal area. This was in her endometrium, and she had a few other types of strep in there as well. It was sensitive to Keflex. She was treated with Keflex 500 BID for 10 days. And again, that reflects that endometrial receptivity problem that we found in her type 3 luteal phase deficiency. Next visit, August, the patient was pregnant. So I was taken back a little bit. It was a little fast right after the surgery. So was the surgeon. This is the baby at 6 weeks and 2 days, and this is her baby at 11 weeks. When I saw her, she was 7 weeks, 6 days. EDD was 4/11/2024. She was on her prenatal vitamins, a little nauseous, a little low appetite, doing well. Now she had moved now because of her husband, or she was going to move. Her husband was transferred to Florida because he had to undergo some training to be a pilot. So she and her husband are moving. She looked for a NaPro doctor to give her routine prenatal care and deliver her baby, but she was unable to get in. So she went with a regular mainstream NDoc, which happens all the time. I help the patients get pregnant. They go to a regular OBGYN for delivery. Oftentimes, I will continue to monitor their progesterone throughout the pregnancy. This patient began spotting at about 6 to 8 weeks, but the ultrasound was normal. She was followed for her progesterone. So this is a NaPro progesterone graph. In the beginning, we check the patients every week. We put in their gestational age, and then we'll put in the progesterone level, and it will map onto this graph. The x-axis is the gestational age of the baby in weeks. The y-axis is the serum progesterone level. And again, these norms are based on 30 years of research. The midline here is the average, and you can see the average progesterone levels as the gestational weeks progress. The dotted line here is 1 standard deviation below and 1 standard deviation above. As long as we can keep the patient in this zone here, we call this zone 2. This is zone 1, 2, 3, and 4. As long as we can keep them in zone 2, the closer to the midline, the better. You can see this patient did very well. Now, I was scheduled to give a lecture on NaPro October 17th. I had asked this patient her permission if I could present her case because it was success in diagnosing the root cause of her recurrent losses and being able to help her get pregnant. So I gave her a call. She was again in Florida, so she wasn't under my care anymore. And she tells me, "How are you doing?" She says, "Yeah, well, at 11 weeks, I had a lot of heavy bleeding. It was really scary. I thought I was going to lose the baby." She soaked through a super pad in seconds and continued through the night, had mild cramping and uterine tenderness. The ultrasound demonstrated 2 small subchorionic hemorrhages, which coalesced by about 13 weeks gestation into 1 large subchorionic hemorrhage, about 14.7 centimeters. I was totally taken back. She said her OBGYN told her there was no treatment other than pelvic rest. So I know in NaPro, we do have a treatment. We will use alpha lipoic acid to help decrease the size of that subchorionic hemorrhage. I actually sent an APP out to my colleagues at My Catholic Doctor to see if anybody had used ALA in second trimester with a subchorionic hemorrhage of this size, because I had only treated patients in the first trimester with very small subchorionic hemorrhages. I got an onslaught of responses from my colleagues from all over the country. They were amazing. Yes, I've used ALA. I've had large subchorionic hemorrhages like this. Everything went well. We've also tried antibiotics. Could be a chronic endometritis returned. So basically, she was told by her OBGYN pelvic rest, which we do as well, no rigorous exercise, no sexual intercourse, no lifting greater than 10 pounds. The patient was an RN. She was unable to work in her profession, so she took a desk job in an airplane repair shop. And as I mentioned, by 14 weeks, she had a very large hemorrhage. This is the outline of her hemorrhage. So this is the baby, obviously. This is the endometrial wall. Here's the treatment: mainstream medicine versus NaPro. Mainstream men in green, NaPro in blue. We both do pelvic rest. NaPro uses alpha-lipoic acid, 300 milligrams BID, and we watch that hemorrhage to see if it resolves. Alpha-lipoic acid has wonderful research to back that it works for recurrent pregnancy loss. It's very easy to find in the literature. It's a potent antioxidant, anti-inflammatory, and has immunomodulatory properties. We also use antibiotics sensitive to the documented chronic endometritis if the patient had had that diagnosis prior to pregnancy. So remember, the patient left my care and she was with a regular OBGYN. The next morning, after I had sent out that APP alert to my colleagues, I had a call from one of the colleagues who said, hey, I know a NaPro doc in Florida. He's willing to see her in his office today at 2 o'clock. I called the patient the next morning. I got her at work and I said to her, hey, listen, this NaPro doc is willing to see you. He'll take you under his wing. He'll deliver your baby. She was overwhelmed with joy. I had given her, quote, education that we use alpha-lipoic acid, and she had already started that. So she was in the NaPro doctor's office the next day at 2 o'clock. It was beautiful and it was amazing. She told me the NaPro doc spent over an hour with her. She also had an ultrasound. The ultrasonographer spent over an hour with her. He did end up following her through the pregnancy. He treated her with clarithromycin. I sent him a fax to let him see the path report. I'm not sure if he missed it or what, but he did want to use the clarithromycin. He used it at a half dose, which scared me a little bit because, as you know, we know there's a bacterial infection, which we were suspecting was the cause of the recurrent subchorionic hemorrhage. We don't want to half dose treat because we're only going to kill the weak bugs and the strong ones are going to replicate. What happened is the patient stopped bleeding. And again, remember, she had been spotting since 6 weeks. Her uterine tenderness resolved right away. She had thought that was normal until she saw that she didn't have it anymore. But about a week later, the uterine tenderness returned. So she reported that to the NaPro doc. He gave her a second round of clarithromycin, this time at the 500 dose BID for 10 days, and her pain resolved. He did do an ultrasound every 2 or 3 weeks. This is a little bit of a typo here. And the subchorionic hemorrhage decreased in size, but never resolved completely. She continued to have her progesterone monitoring. I believe she missed the dose the night before. When we're doing progesterone monitoring, we get trough levels, so the patient has to remember to skip the dose of progesterone she's taking the night before. And she had a beautiful baby, Charlotte Anne Marie, that was born on March 23rd, 2024. She was 38 weeks and 1 day. I forgot to mention that we do stop progesterone around 36 to 37 weeks. We don't want to keep the patient on progesterone and delay her delivery. So patient had tested positive for GBS, not a surprise. It was the same pathogen that we had found in her chronic endometritis. By her report, the placenta was delivered in pieces, and I did get the path report, and the placenta was unable to even be weighed because it was in pieces. You can see she had acute inflammation. She had acute infection. She had a chorioamnitis. She also had, this is the intervillus of the placenta itself, and this is the area where the umbilical cord stump joins the placenta. And she did give me permission to put her picture here. So this is MR. This is her husband, who now is a pilot. This is the baby at their baptism. And here's beautiful Charlotte. And as you can see, this is a 33-week 3D ultrasound. And look at the similarities in these images. Aren't they beautiful? I always have to give a little plug for a book that I love. It's called Men, Women, and the Mystery of Love. NaPro Technology, again, treats the whole patient. We use, all of my treatment is based on research. If the research looks quality, I use the treatment. And there is a ton of research out there to support what we're doing. I always talk to the patient about authentic love. I encourage this book. I love this book. It's written by Edward Street. It is a paraphrase of JP2, our former Pope. He wrote an encyclical called Love and Responsibility. And it basically teaches true love, and it cuts to the heart, because when people hear the truth, it cuts to the heart and they want it. So it usually helps every marriage to grow. And we teach them that the act of sexuality is really a symbol for the commitment that they're making to each other, basically to commit for the rest of their life, to sacrifice for each other, and to even die for each other. These are my references. And I want to thank you very much for joining me for the lecture.